symposium. Dr. H.S. Bhat doesn't require any introduction. He is the father of urology of our country. But for the foreign delegates and youngsters who may not be knowing much about him, I'll give a small snapshot of his life. He was born to A.R. Bhat, a soldier in British Army in Udupi, graduated from Stanley Medical College, then got masters from CMC Vellore. He went to US with Rockefeller's fellowship, got trained with Masters of Urology during that time, came back to India, established the Department of Urology in Vellore, pioneered the endoscopic surgery, and established the first renal transplantation program, successful renal transplantation program in India, trained many of our senior urologists, then was awarded the prestigious B.Z. Roy Award. After retirement, he came back to Bangalore and finally settled in Puttaparthi and had spiritual life. But he trained urologists till his last breath in 2010 at Sri Sathya Sai Institute. Few of the teachers and mentors, among which Drs. Raghavachari and Professor Roger Barnes, require special mention. He is a great teacher, motivator, a family person, and is known for his strength of character and vision. Senior urologists in our country like P. Venugopal sir, Ganesh Gopalakrishnan, Dr. Shashidharan, consider him as either his teacher or a mentor. And he is instrumental in establishing our association, considered to be the father of urology. This is a photo of the first meeting that happened in Vellore under his guidance, which was the starting point of urology. And he was close with a lot of people, important people in the society like Amitabh Bachchan, Jayaprakash Narayan, and Sathya Sai Baba was his spiritual guide. He was married to Dr. Prema Bhat, who is a microbiologist, and was a companion for him throughout his life. And they finally settled in Puttaparthi and established the Department of Urology in this institute. He is a great clinician, and his words of wisdom has to be read by all. And he told once that great teachers are those who pass the enthusiasm to the students who are assigned to them and help them to develop further on their ideas. And I'm extremely thankful to him. And I've got a special connection because I was trained and mentored by his own son, Sanjay Bhat, and this is a special moment for me being able to talk about his father. With this memory, I'll go to our session, that is H.S. Bhat Symposium. We have got 4 sessions in this one. Each session is about one malignancy. All the malignancy will be covered. In the first session, we have got 2 talks on renal tumor. First is by Dr. Raghavan, second by Dr. Kalyan Sangan. Dr. Raghavan is from Apollo, Chennai. Raghavan, please, the talk on the importance of image guidance in partial nephrectomy.
Thank you so much, Ginil. Shall I share a presentation or are we going to play the video?
Sir, playback has started. Partial nephrectomy is now the preferred management of T1A, T1B, and many of the T2 tumors as well. The key is to give oncological clearance with maximum functional preservation. And for this, we need to have a very good understanding of the tumor characteristics, hilar anatomy, and vascular anatomy. And this is done using a preoperative CT scan. However, the preoperative CT scan has a limitation of a 2D model. What is available now are 2, printed modeling and virtual modeling in terms of 3D. The printed model advantage is that it is very accurate. You can have a touch, you can feel, you can rotate, but it has to be printed. There is a cost involved to it, and there is a man time involved to it as well. The virtual model is interactive. You can add and subtract the structure as you see it. However, it needs a very highly trained technical team and a radiological support, and therefore it is not widely available at this point of time. The interactive 3D modeling, which is a virtual modeling, allows a 360-degree manipulation of the anatomical structures in all its axes. And it allows individual to remove the structure, like for example, you can remove the tumor, see what is inside that for us to understand what we are going to suture and so on and so forth. We can also remove the kidney and see the anatomy, the relationship of the tumor to the vascular anatomy as well. You can see it in the multiple windows, like say smartphone, laptops, or tabs. The advantages of virtual 3D reconstruction, it has advantages to understand the vascular anatomy well, the hilar anatomy well, the proximity of the hilar structure to the tumor, assessment of the loss of cortex, and hence the clearance as well as functional preservation. It helps us to understand where the incision will be made. It helps us to understand how much of renal function preservation we can achieve with the tumor. It helps us to understand the hilar anatomy, especially in relationship to vascular and PCS structures. The operative times come down with the 3D model. It is also easier to train the patients as well as the trainees to make them understand what exactly is going to happen on the operating table. I'm going to present some case-based scenario. Here we have a 26-year-old patient who presented with an incidental right exophytic mass, which is completely intrahilar. As you can see, the structure is playing the arterial supply and has encroached into the renal parenchyma a lot. The underlying renal parenchyma is thinned out, but he is a young man, so we wanted to understand whether we can do a preservation of this kidney. What I chose to do is to do an open partial nephrectomy for this patient in order to understand and give him the best opportunity to preserve the kidney. And what we are seeing is the 3D reconstruction on the left side and the real-time photo of the surgery. You can see very clearly the 3D reconstruction and the real-time photo are 100% matching. That's a tumor. The patient had a permanent grade 1 clear cell tumor with clear margins. And the 3-month follow-up CT showed a completely functioning kidney as well. The second case, I'm highlighting this case to make you understand the advantage relates in relation to vascular anatomy. This patient had a very complex vascular anatomy, 3 arteries, 3 veins, a complicated gonadal vein draining into the renal vein. That we understood because of the preoperative reconstruction. The patient also had a lot of comorbidities. We wanted to keep the operative time very short. So we wanted to just go in and come out, and that's where the 3D model came to play. Here it clearly shows that the tumor is exactly same as the 3D model shows. The arteries, the first set of artery, as you could see, along with the corresponding vein, the clamp is going into that. The second is the main artery, where you can see that as well, and the clamp is going into that as well. So what I'm saying to you is that 3D modeling helps us to understand the vascular axis much better, and will be able to help us to understand where to incise the tumor as well. For example, this patient, you can see the 3D model and the real-time operating model or real-time operating picture are exactly the same as well. This is a 59-year-old, he had mild pelvic pain, showed a right large hilar mass with a single renal artery, but it was lying bang in the interpolar region. And there was a retrocaval branch as well. So all this information we got from the 3D model. It was a partial exophytic, largely endophytic tumor. So we went ahead and did a robotic partial nephrectomy on this patient, which clearly understanding what we are going to do and clearly explain to the patient that we may not be able to do a 2-layer rhinography, and we had to get the inner layer correct and accurate. So as expected, it was a large surface area, and what we did was just a single layer rhinography. In addition, the patient also had a toxic fat, and the 3D model allowed me to just go directly to the place of interest rather than where we may otherwise be struggling to find it. That is the inner layer which is being done. And you can see the 3D model and the real time are exactly the same. The case 4 is a very complicated VHL tumor patient. The first impulse for me is to sacrifice the kidney, but after a long discussion, we thought we'll make an attempt to preserve the kidney by doing a partial. I wanted to do only an open partial because I thought that will give him the best chance of preservation. It was a very complicated intrahilar mass, as you could see, with the complicated both the pelvic calyceal system and the vascular structures around it. But the good news is that we managed to preserve the kidney for this patient by an open partial nephrectomy, and those are the findings. You can see very clearly the finding as you see in the 3D model is the same as you see in the real-time surgery as well. 3D modeling, both printed and virtual, offers very good understanding during the perioperative assessment of partial nephrectomy. It has multiple clinical advantages to surgeons, patients, and trainees. The current limitations, the availability of technology and the technical support and the financial burden. We are hoping that with time, we will be overcoming that and it will be available widely for everybody. Thank you so much.
Thank you, Raghavan, for the excellent presentation. Dr. Kalyan Sarkar, do you want to comment anything about Raghavan's presentation? Because you have seen the evolution of radiology and CT in the treatment planning. Any comment or...
I think amazing developments have happened. The only thing which bothers me these days is the fact that the time required for the surgery and the lack of intraoperative cooling. To do perfect surgery, to protect maximum renal function. I think open surgery gives you a lot more comfortable time to do complex procedures. So maybe those very difficult surgeries you did, I could see that some of them were indeed done open with cooling.
Yeah. So one question, how does one compare CT angiography with 3D modeling in vasculature, Raghavan? One question from audience.
The standard CT that we do, the 3D model is done from the standard CT we do. But somehow the software that we are having on a daily basis in our radiology department can only show that vasculature in a stepwise fashion. Literally, you go and sit in the radiology suite and sit with the radiologist and see it. But then when you come to the OT, after 3 or 4 days, when you have seen that and come to the OT, you will not be able to recapture what you have seen there. The 3D modeling, the virtual 3D modeling, literally translates. You take the whole experience of whatever you saw in the radiology suite to your operating room and put it and there.
You do 3D printing?
Sorry?
You do 3D printing?
No, I don't do 3D printing. Okay. I just do the virtual model. The vascular anatomy, what is the exact relationship of the tumor to the intrahilar artery or the vein? What artery will cut and what artery will suture? That much you will know.
Thank you, Raghavan. Yeah, it was an excellent presentation. Dr. Kalyan Sarkar, your talk on the recent advance in metastatic RCC, we are waiting to hear. Yeah, thank you.
Good morning. My brief today is to talk about the recent advances in the management of metastatic renal cell carcinoma, and I'm going to talk about recent developments in cytoreductive surgery, immunotherapy, and targeted therapy. We know that the CERTIME and the Carmina trials of cytoreductive nephrectomy have been developed to address the issue as to the timing and the optimization of patient selection for cytoreductive nephrectomy, with the observation that poor risk patients with life expectancy of less than 1 year do poorly with upfront cytoreductive nephrectomy. It is well established by retrospective studies that there are improvements in overall survival and progression-free survival. The Carmina trial, in its after analysis, indicates that for most intermediate and poor risk patients, upfront sunitinib with deferred nephrectomy, depending on the response to sunitinib, may be the appropriate way forward. But certain subgroups, including patients with one IMDC risk factor, may still benefit from upfront cytoreductive nephrectomy. The CERTIME trial explored the timing of cytoreductive nephrectomy with either immediate sunitinib followed by delayed cytoreductive nephrectomy or immediate nephrectomy followed by delayed sunitinib. Progression-free survival, overall survival was improved in the deferred nephrectomy group, whereas if one started performed immediate cytoreductive nephrectomy, there were administration onset and duration of sunitinib therapy was not optimum. So upfront nephrectomy has a role with patients with only one risk factor and good performance status, delayed nephrectomy for intermediate and poor risk patients who have shown a good response to systemic therapy. This 52-year-old lady who presented with a 7-centimeter tumor and a 2-centimeter cervical lymph node metastasis without any comorbidities is an ideal patient for cytoreductive nephrectomy because of anticipated systemic immune responses. This 60-year-old man with multiple liver and lung metastasis, but a good performance status, may be the right candidate for initial treatment with sunitinib followed by delayed cytoreductive nephrectomy. Patients with poor ECOG status, high Fuhrman grades, liver and brain metastasis, and high tumor stage 2 whole. Immunotherapy or immune checkpoint inhibition with anti-PD-1, PD-L1, anti-CTLA-4 therapy is the talk of the day. The role of multi-kinase inhibitors are being defined. A combination of immunotherapy with VEGF-targeted therapies were explored in the EMOTION and the Javelin trial, and were very carefully analyzed in the Checkmate 214, Keynote 436, Checkmate 9ER, and CLEAR trials. The first one is the ipilimumab, nivolumab combination. The others are combinations of TKIs with immune checkpoint inhibitors. And it is amazing that all these combinations, the IO combinations and the IO-TKI combinations, show excellent response rates, acceptable side effect profile, and overall survival has not been reached in many of these trials. These are practice-changing data. And nivolumab with ipilimumab has become the global standard of care for MRCC patients with intermediate or poor risk disease. The response is durable and side effects are manageable. Arguably, immunotherapy has its side effects needing steroid therapy, especially the autoimmune manifestations, but the TKI inhibitors have their own range of severe side effects with treatment dropouts. The other big advantage of immunotherapy is that the treatment may be withdrawn after a period and response is maintained. In second-line trials, the paradigms are being defined with anti-PD-1 for those previously treated with TKI and cabozantinib for those previously treated with anti-PD-1. Metastatic non-clear renal cell carcinoma and sarcomatoid tumors have response to immunotherapy. And this patient, the 67-year-old female with widespread deposits all over the body, would be an patient ideally suited for IO-TKI therapy. Whereas this patient with a poor performance status, with a good performance status, but poor risk categorization would be considered for either IO or IO-TKI therapy. So in summary, cytoreductive nephrectomy and metastasectomy retain a role. Cases have been selected judiciously. There are new standards of care for first-line therapy. Second-line treatments are being defined. Non-clear cell cancers can be appropriately treated with anti-PD-1 and TKI combinations. And new trials are afoot to answer the various other questions which are coming up. And thank you very much indeed.
Thank you, Dr. Sarkar. Due to shortage of time, we'll go to the next session directly and take the questions in the end. I invite Dr. Sudhir Raval for a presentation of his techniques in neobladder. Sir, please.
Can somebody play the video, please?
Good morning, everyone. My topic is about orthotopic intracorporeal neobladder. What are the steps? The neobladder which we do is called as just spot ileal neobladder. We generally harvest around first 20 centimeter, around 25 centimeter proximal to ileocecal junction. We take first stitch, and then second is 20 centimeter proximal to that. And third one is again 20 centimeter proximal to this. So around 40 centimeter is used for the making the neobladder, and 15 centimeter more is used as a limb. This is the stapler which has been used by assistant, mainly Ethicon and Covidian provide these staplers, but nowadays we have a stapler from Da Vinci also, which we are using regularly. This mesentery is cut from proximal and at proximal and distal end, and then ileoileal anastomosis is done. While doing ileoileal anastomosis, we take 2 stage suture, 2 or 3 stage suture, depending on the requirement on the anti-mesenteric border, so that it does not rotate and the stapler does not fire at the mesenteric side. This is how it is done. You insert a 60 ml endo GIA, and generally we use 2 endo GIA so that the lumen is good. Once this is done, then we fire another endo GIA at the end. And this is the pictorial view of how the neobladder is actually done and how the harvesting of segment is done. Such segment is taken to where. Then detuburization done at the anti-mesenteric border. Going proximal towards the proximal side, around 18 centimeter from the place where we started, and taken around 2 to 2.5 centimeter towards the mesenteric side, so that we can make a tongue-shaped flap, which is later on tubularized. It gives extra length of around 2.5 centimeter to reach to the urethra. We continue here another 20 centimeter towards the extruder limb. And this is how the picture will occur once you take the posterior plate. We are taking posterior plate now. You can see the suture in posterior plate. We put 3 to 4 interrupted suture using 20 Vital, so they will help in healing. When these stitch suture are interrupted sutures are taken, then we take 30 V-lock and suture the bladder of the we start with posterior plate of the bladder. This is the bladder formation. First posterior plate like this, and then next will be taking this point to here, X dash point to X. But before that, we will do the tubularization of the flap, which we actually made when we went proximal towards the mesentery, around 2 to 2.5 or 3 centimeter in length. So this is the tubularized neo-urethra, you can say, which will be anastomosed to the original urethra. And when you bring X to X, X dash to X, then the shape becomes of the complete spherical, and that is why we call it a church spot, because it resembles the surai, that is Indian earthenware. Especially in North, it is used for in the summer season like this to cool the water, and that probably that water maintains the taste also. It was very common when I was young. We are taking on each side to close this completely and making it a spherical shape. And in between, the interrupted suture will be given on both the limbs also. After that, the bladder is anastomosed to the original urethra. The ureteric anastomosis is done later on. You can see it is easily reachable. That's the best part of the whole technique. CIC rates are almost negligible in our technique. So this is ICG being used to see the blood supply of ureters. So you can know that there is nothing wrong has gone. So after this, we take one ureter and anastomose to the ileum in a Nesbitt's technique. Part of the coin shape, part of the intestine is removed, including the glucosa and serosa, so that the stricture is not there later on. output side at the apex, the sutures are taken. We have to do generous speculation on the ureter and always take on the ureteric valve on the ureter side. Rather than taking hold of the ureteric sheath and periureteric sheath and everything, please do not do that, because that contains the vessel and sometimes the necrosis can occur of the ureter and you may end up with the ureter. For closing, we put in fan-feeding tube which comes out of the abdomen. Then it is fixed to the ureter. We fix it to the ureter, we do not fix it to the ileum. As possible. And then you make another hole for the next ureter. You take out the stellate through this hole and then through the mesentery. Mesentery of the shoulder limb. The mesentery of the shoulder limb is when you bring out the mesentery of the shoulder limb, when you remove your infant feeding tube, then the healing is faster. Now this is another side of the ureter. And same way, this will be anastomosis to the ileum. And these both infant feeding tube, they will come out of the one of the cannula and onto the abdominal wall, and the incision is closed after removing the specimen from the very small incision around the umbilicus, around 4 centimeters.
Thank you, Ganil, for giving this me opportunity.
Yeah, thank you. We will switch on to the next talk. That is the advance in bladder malignancy management by Dr. Hemang Bakshi. Hemang Bakshi is from Ahmedabad, a known uro-oncologist from Ahmedabad. He is working in HCG hospital. Welcome, sir.
I'm to speak on the recent trends in the management of metastatic bladder cancer. Over the last 2 decades, platinum-based chemotherapy has been a standard of care in metastatic bladder cancer, but the responses are not durable, and half of the patients do not receive second-line therapy. 2 out of 3 patients progress within 9 months, and the overall survival is poor in the range of 12 to 15 months. Even those patients who receive second-line therapy, which is about 70%, the OS and PFS is in a matter of few months. So, for those patients who are cisplatin ineligible based on these criteria, it is important to remember that 75% of these patients will still be eligible for carboplatin therapy, and this can be used as a first-line option in those patients who are ineligible to cisplatin. For those patients who are completely ineligible to both cisplatin and carboplatin, 2 trials have evaluated the use of immunotherapy in this setting. One is the IMvigor 210 trial, which evaluated atezolizumab, and it gave an overall survival rate of 15.9 months across all comers. And the second trial was the Keynote 052 trial, evaluating pembrolizumab, and it also showed a good overall survival of 18.5 months in those who had a CPS of more than 10%. So these were positive trials, and pembro or atezo are approved by the FDA for PD-L1 positive cisplatin ineligible patients. And for those patients who are completely ineligible to any platinum therapy, they are also approved regardless of the PD-L1 status. Now, what can be used to maximize overall survival? What approaches? Standard approach is wait and watch, first-line chemo, disease progresses, initiate second-line chemo. These are we have been doing since 2 decades. And an exciting option is switch maintenance, where we give first-line chemo. If the disease does not progress, we give switch maintenance immunotherapy. And then when the disease progresses, we initiate second-line. Another exciting option is first-line chemo and immuno. And then when the disease is stable, continue immunomaintenance, and then initiate second-line therapy. Now, whether this option translates into better Overall survival, well, conceptually, yes. Theoretically, it is a good option because chemo will prime the tumor for ICI treatment and delay disease progression when first-line maintenance is given by immuno and the need to start second-line therapy. Whether it does in practice was evaluated by two trials. One was the IMvigor 130 trial, second was the Keynote 361 trial. IMvigor evaluated atezo plus chemo and the median OS was 13 versus 16 months, not significant. And Keynote evaluated pembro plus chemo versus chemo alone. Again, the OS was not clinically significant, 14 versus 17 months. So if you consider progression-free survival in these trials, again, there was not much of a significant difference, 6 versus 8 months, 7 versus 8 months. And these two trials are considered negative. And a third trial called the DNB trial also evaluated immunodoublet durvalumab plus tremelimumab and did not meet OS endpoints. So all these trials evaluating combination therapy, chemo plus immuno or immuno plus immuno, did not give much benefit. Exciting option is the Javelin trial, Javelin bladder 100 study, which evaluated after first-line chemo maintenance avelumab versus best supportive care in those patients who did not progress. The primary endpoint was overall survival, and the overall survival benefit was 14 versus 21 months, so 7 months clinically significant. And the risk reduction in death was 31%. The progression-free survival was 2 versus 3.7 months, again clinically significant. And for those patients who were PD-L1 positive, the risk reduction in death was 44%, even better. Subgroup analysis showed that it benefited all subgroups, regardless of chemotherapy status, response to chemo, regardless of renal function, and regardless of PD-L1 status. As you can see from these forest plots, the benefit was seen all across subgroups. So the Javelin trial, the adverse effects discontinuation treatment rate was 11.9%, and it was pretty well tolerated in most patients. 9% required steroids. Now best survival rates was obtained with this combination. First-line chemo, no progression of disease, switch to maintenance avelumab, and then go to second-line immunotherapy. Survival was 26.5 months, which is much better than these other regimens like chemo followed by immuno, chemo-immuno followed by immunomonotherapy or immunotherapy. So this by far is the best treatment right now. And second line immunotherapy, atezolizumab and durvalumab is withdrawn the approval because it did not meet the requisite standards, and pembro is the best treatment available right now. So all guidelines, NCC and ESMO and EA, have incorporated maintenance avelumab as level 1 evidence in the current paradigm in metastatic urothelial cancer. For those who are cisplatin eligible, they will go to cisplatin-based chemotherapy. For progressive disease, anti-PD-L1 or anti-PD-L1 immunotherapy. Non-progressive, switch maintenance avelumab. And third line is ardafenib and enfortumab or sacituzumab. For those who are cisplatin ineligible, which is less than 10%, pembro or atezo is the treatment of choice, and then followed by second-line therapy in form of ardafenib or sacituzumab.
Thank you.
Thank you so much for your efficient hearing.
Yeah, thank you. Thank you very much. It was an excellent presentation covering almost everything, and we are very much excited about the Javelin trial. There is no questions in the chat box, so we'll switch over to shift to the next presentation. Next duet is on two tumors. One is testicular tumor. Second is on carcinoma of penis. First talk is by Mahendra Pal from TMC Mumbai about the role of the evolving role of RPLND in non-seminamatous germ cell tumor. Over to you, Mahendra.
Hello everyone, and thank you, Dr. Ginil, for inviting me to give a talk in prestigious Bhat Symposium in USICON 2022 on primary RPLND and LHSTT, the role we revisited. RPLND remains an integral part of treatment of LHSTT and potentially curative in stage 1 and 2 disease. And it is important as approximately 10% of the patient with no nodal involvement on imaging will relapse, as there is an increased risk of recurrence with presence of LVI and predominant annual carcinoma in the primary. And a study by Andrew J. Stephenson in a 453 patient who underwent primary alkalinity for clinical stage 1 to 2B disease, and they found that in presence of high-risk features, and there is a 22% incidence of teratoma. They propose that primary alkalinity can be offered as a proper primary intervention in the patient with clinical stage 1 to 2A disease. And the same author compared primary alkalinity and the primary chemotherapy in stage 2A and 2B disease, and they found that disease-specific survival is almost similar in both the arms, and they concluded that primary alkalinity can be offered to the patient with normal post-operative serum tumor marker and with a solitary retroperitoneal mass less than 2 cm in size. A review article in 2020 they found that primary alkalinity should be performed with the rationale of retroperitoneum being the most common site of metastasis and presence of chemo-resistant teratoma. And they proposed that risk-adaptive approach for primary alkalinity can give better oncological outcome, and up to 90% of the patient adequate ejaculation can be preserved. So, if the risk-adaptive approach is applied for the NSGC stage 1 and 2A, so for the clinical stage 1, primary alkalinity in the form of non-sparing alkalinity can be offered in the patient, in the low-risk patient, in which surveillance and chemotherapy has not been chosen, and in high-risk patient, only if chemotherapy is not chosen as a standard treatment. And it has a strong recommendation in EU Guidelines 21. About the clinical stage 2A disease, non-sparing alkalinity can be performed in the patient with negative tumor markers, or in the patient with progressive disease but negative tumor markers. 81% of the patient who has confirmed pathological 2A disease were cured by the primary alkalinity, and they did not require any adjuvant therapy. So it has a weak recommendation in EU Guideline 21. Now coming to nerve-sparing alkalinity, anatomically the nerve fibers travel in front of aorta and behind the IVC. This is our patient who certifies as the clinical stage 2A. Retroperitoneum being exposed after lifting the bowel through the root of mesentery. Boundary of standard alkalinity is defined. Here we can see the gonadal vein, the left renal vein, all the major lymphatics which came across should be either ligated or clipped. This is right renal vein, left renal vein identified as a loop. The final template of dissection is defined. As we can see in this figure, splitting of lymphatic tissue started in front of the IVC, as there are no nerve fibers. Find here. The intraperitoneal nodal tissue excised. The nerve fibers identified at the intraperitoneal region with the soft section, and they were looped. Loop can be used as a traction which can facilitate the dissection of the nerve. The key point over here is one nerve fiber leads to other nerve fibers, so we should try to preserve and save whatever the nerve fiber we find. Total tissue between the nerve branches has been dissected carefully. A paracable dissection is done to identify the sympathetic chain and the major branching of nerve nodes. They also looped around the aorta. We should be very careful by dissecting because the many nerves are in front of the aorta, and at the hilar area. We should be very careful by dissecting to avoid any injury to the renal vessels, and proper clipping to be done to avoid post-op leak. We should use minimum use of cautery. All the major nerves are being looped. Around the IMA we can find the large ganglion. The fibrous tissue between these nerves also being excised while saving maximum nerve fibers. This ganglion is continued as the bifurcation and make the part of hypogastric plexus. So, complete camera section with the reservation of blood vessels is done. Here we can see lumbar vein and the sympathetic chain of right side. At last, the inspection for the completion of dissection is done. And to confirm the final result. But one thing should remember, margin of resection should never be compromised in a time to preserve anti-ejaculation. So take home message, RP lending is an integral part of management of NSGCT. Primary RP lending in the form of specific RP lending has selective indication clinical stage 1 and 2A. Primary RP lending has comparable outcome with primary chemotherapy in clinical stage 1 and 2A. In-depth knowledge of retroperitoneal not is the key. Oncological outcome must not be compromised over functional outcome, and this surgery should be performed by an experienced surgeon in a specialized center. Thank you.
Mahendra, it was a great video, and I really appreciate seeing the video. I think that we have to restart RPLND because a lot of people have abandoned it, but restart at least in selective people who will be benefited considering the morbidity of the chemotherapy. Thank you very much. We'll take the question one in the end. At the end we will take considering the shortage of time. We'll switch on to the next talk by Dr. Amlesh Seth, head of the department of at All India Institute, about carcinoma of penis, where we require a lot of clarity on the management. Sir, Amlesh, sir.
Good morning, ladies and gentlemen. My mandate today is to talk about N+ groin in patients of carcinoma of penis. The importance of lymph node staging is that lymph node metastasis is the single most important prognostic factor for survival. Although there are differences in the TLM staging between AJCC, UICC, and EAU, the EAU staging system is what I am going to use today. And I am going to talk about N1, N2, N3 disease. One common factor between testicular cancer and penile cancer is that in both there is a stepwise predictable lymph node metastasis. The N+ groin management, there are a number of issues to be discussed. The first issue to be discussed is whether these patients should be treated with antibiotics and check whether the lymph nodes subside on antibiotics or not. There is ample evidence to suggest that in patients who have palpable lymph nodes, more than 70% of these palpable lymph nodes would be metastatic. Therefore, there is no justification for treating them with antibiotics. In terms of radiological evaluation, there is a strong evidence that in patients who have palpable lymph nodes, a CT scan of the abdomen and pelvis should be added. FDG PET, if added, adds significantly to the sensitivity and specificity of the CT scan. In this paper published in the year 2005 from Harvard Medical School, if lymphotropic nanoparticle enhanced MRI is done, then sensitivity, specificity, positive and predictive values all are increased. The management of lymph node metastasis will depend upon whether it is N1, N2 or N3 disease. In patients who have N1/N2 disease, in a systematic review published in Nature in the year 2017, cure rates of 85 to 88% have been reported with surgery alone, that is inguinal lymph node lymphadenectomy. Therefore, there is a strong recommendation in favor of radical inguinal lymphadenectomy in patients with CN1 and CN2 disease. In patients with CN3 disease, although the recommendation is weak, but the standard of care remains neoadjuvant chemotherapy followed by radical inguinal lymphadenectomy in patients who respond well. The NCCN recommendations are slightly different. NCCN emphasizes a lot upon biopsy, especially in a situation where the primary is low risk and the lymph nodes are palpable. The other difference is that NCCN gives a lot of options and also considers neoadjuvant chemotherapy as an option in patients with N1, N2 disease, and also considers post-op radiotherapy in patients with N1, N2 disease, and also considers chemoradiation as one of the options. Whereas radiation therapy is not considered a good option by EAU. Even in NCCN gives all the options like cisplatin-based chemotherapy. The good thing is that cisplatin-based chemotherapy has come as number one recommendation, but the other options also remain like primary surgery and chemoradiation. What should be the indications for pelvic lymph node dissection? In patients who have 2 or more lymph nodes on that side or have extranodal extension, the pelvic lymph nodes should also be removed. What should be the indications for adjuvant chemotherapy? Those patients who have more than 2 positive lymph nodes, have bilateral positive lymph nodes, extranodal extension, or positive pelvic lymph nodes, adjuvant chemotherapy should be added. The chemotherapeutic regime that is recommended the most commonly is the TIP regime, although 5-FU and cisplatin have also been recommended. The open inguinal lymph node dissection remains the standard of care, although there is some data to suggest that rail and robotic rail may have better early outcomes, but long-term results are awaited. The boundaries, the standard boundaries are well defined, and even the boundaries of Catalona's lymph node dissection are well defined. Although there are no head-to-head randomized controlled trials between Catalona's and standard inguinal lymph node dissection, the Catalona's continues to be used in patients with CN0, CN1, and even in CN2 disease with less morbidity compared to the standard inguinal lymph node dissection. The oncological outcomes in patients who have limited lymph node disease, cure rates of 85 to 88%, but if there are extensive lymph nodes, then the cure rates come down, and even cure rates of 0% have been reported, but one should expect 20 to 50% as the cure rates in that situation. In patients who have pelvic lymph nodes that are positive, again, one should expect cure rates between 20 and 50%, although the cure rates of 0% have also been reported. In the final take-home messages, in patients with N+ disease, don't delay definitive treatment with antibiotic course. In C1, N1, N2 disease, radical inguinal lymph node dissection can be curative in patients up to 85 to 88%. Patients who have N3 disease, they should be treated with neoadjuvant chemotherapy followed by surgery, and robotic rail perioperative outcomes are good, but long-term results are awaited. Thank you very much.
Thank you, sir. It was an excellent talk on the management of lymph node positive CFAs.